Title: Pseudomonas resistance. What actually matters at the bedside? Let's be honest. Pseudomonas aeruginosa is not difficult because it's rare. It's difficult because it's engineered to resist almost everything we throw at it. If you don't understand its resistance mechanisms, you're essentially prescribing blind. Today, I'll break this down into practical, clinically relevant concepts you can actually use. The problem. Think of Pseudomonas as having four major defense systems: enzymatic destruction, reduced drug entry, active drug efflux, target modification. Most resistant strains don't rely on just one, they stack mechanisms, which is why therapy fails. 1. Enzymatic resistance, the big one. The most clinically relevant mechanism, beta-lactamase production. Key players: AMP-C, chromosomal inducible, upregulated during therapy, especially relevant with cephalosporins, can lead to on-treatment resistance. ESBLS, less common but present. Carbapenemases, KPC, Class A, VIM, IMP, NDM, metallo-beta-lactamases, OXA type, Class D. Important clinical point. If you're dealing with MBLs, like NDM or VIM, then most beta-lactams fail, including newer agents, unless you use combinations like ceftazidime avibactam plus aztreonam 2. Porin loss, OPRD. This is the classic mechanism for carbapenem resistance. Loss or mutation of OPRD porin primarily affects imipenem, meropenem. Key insight: not all carbapenem resistance equals carbapenemase. Sometimes it's just porin loss plus AMP-C. That distinction matters because you may still have activity with newer beta-lactam/beta-lactamase inhibitors. 3. Efflux pumps. Think MEX-AB-OPRM system. Pumps antibiotics out of the cell. Effects: fluoroquinolones, beta-lactams, some aminoglycosides. Clinical implication: leads to multidrug resistance phenotype, often subtle in the lab but clinically relevant. 4. Target modification. Less dominant but important. DNA gyrase mutations lead to fluoroquinolone resistance. Ribosomal changes lead to aminoglycoside resistance. Also, biofilm formation. Not a classic mechanism, but critical. Seen in VAP catheters, bronchiectasis. Biofilms equals antibiotic tolerance plus persistence. Clinical take-home. Here's how to think at the bedside. If resistance emerges during therapy, then think AMP-C induction. If carbapenem resistant, ask carbapenemase or porin loss. If MDR phenotype, likely efflux plus multiple mechanisms. Always integrate microbiology data, local antibiogram, patient context, ICU, prior antibiotics, devices. Conclusions. Pseudomonas doesn't rely on one trick, it builds layers of resistance. And if you don't think mechanistically, you will always be one step behind. Don't chase resistance, understand it.